హలో లాగన్ అవ్వండి.
Achyut, shall we start? Exactly time is 7:30. Achyut, you are not audible. Hello?
Achyut, your mic is muted.
Yeah. I unmuted.
Good evening.
Yeah. David sir, go on.
Yeah. Good evening, all. On behalf of ISCCM Visakhapatnam chapter, I am Dr. John David, Chairman ISCCM Visakhapatnam branch. I welcome Dr. Anirban sir. Thank you so much for accepting to talk this topic. Last 2 years, we are all concentrated on COVID-19 and COVID-19 related issues. And we forgot the evergreen topic of sepsis. And we actually want to brush up with a good speaker, Dr. Anirban Hom Chaudhary. We want to have talk on sepsis management, what is new. So many protocols have come, and recently surveying sepsis guidelines, new guidelines have come, and Dr. Anirban Chaudhary sir is going to talk on this topic. And we request all the audience, please make sure of this, make use of this talk in your clinical practice. Now I request Dr. Achyut, Secretary of ISCCM Visakhapatnam branch, to continue the proceedings. Achyut, please go on.
Please. I thank Dr. David, Chairman of ISCCM Visakhapatnam. It's a privilege for restarting the academics with a star speaker, Dr. Anirban Hom Chaudhary. To introduce Dr. Anirban Hom Chaudhary, he has given us a single slide CV, but that speaks a lot about him. He is not an ordinary intensivist. He is an extraordinary professional with lots of feathers in his crown. Very brief introduction. Probably I need to add a lot more to what I am talking now. So Dr. Anirban Hom Chaudhary, I hope I'm spelling it right, Dr. Anirban. Is it exactly Anirban Hom Chaudhary?
Yeah, you are perfectly right, Dr. Achyut.
Right, thank you. So he is Director and Professor of Anesthesia and Critical Care from GB Pant Hospital, New Delhi. And his areas of interest are mechanical ventilation, sepsis, and clinical research. And he is an expert committee member in multiple professional and political bodies, So he is a member of National Medical Commission, National Board of Examinations, New Delhi, AIMS, New Delhi, Institute of Liver and Biliary Sciences, New Delhi, DCGI and UGC, New Delhi. And he has 57 publications. I'm sure he is much younger than this 57. And he has contributed to 16 chapters in various books, and he has one patent to his credit. And he has received multiple awards. To name a few, Sarvepalli Radhakrishnan Distinguished Professor Award in 2021, a Presidential Citation from ISCCM 2019, an Award of Excellence from ISA 2018, and an Honor of Excellence from ISCCM 2016, Delhi Pradesh Bhagirath Samman from in 2014, and Asian College of Pharmacoepidemiology Award in 2013. This is the information provided by Dr. Anirban, and I request Dr. Anirban to add a few more, like if he feel necessary, or we would like to know where your graduation and post graduation are from, and I'm sure you would add a lot more, which is new to the sepsis management, and we would like to invite the discussion on this from various participants who are intensivists, and they do deal with a lot of sepsis patients in our, we all deal with a lot of sepsis patients in our day-to-day professional life. And before I request Dr. Anirban, I request Dr. Mohan Maharaj, who is executive committee member from ISCCM and proud resident and member of ISCCM Visakhapatnam chapter, who is the main reason for and who requested Dr. Anirban to be a part of this symposium today. I request Dr. Mohan Maharaj to say a few words, and then we will move on to the academic session. Over to Dr. Mohan Maharaj, sir. Sir, can you please unmute your mic, sir? Dr. Mohan Maharaj, sir.
Hi, Anirban.
Hi, sir. Good evening.
Good evening. Good evening. Thank you, Achit, for a very nice introduction of Anirban. But the same thing, I just want to only add one point. That is, Anirban is a research person, a resource person, and very resilient person. And he is a very good human being with a lot of different mannerisms. Everything is very nice of him. And he's MRM co-guider, and he is the one who is having ISCCM MRM. We teach us well. And thank you. With this, I request the Anirban to start the class. Thank you.
Thank you, Dr. David, Dr. Achyut Gungada, Dr. Mohan Maharaj, and all the executive members of ISCCM Visakhapatnam chapter, and all other members on this platform who are regulars, and all of them who are present. So at the very onset, I wish to thank for your kind invite and for providing me with this opportunity to interact on a subject which is very close to all of us, but on which we have missed opportunities to discuss because of the COVID, as Dr. Achyut has already mentioned. So since this topic is a bit too big, so without wasting any time, I just want to move on to the subject. And as we walk along with me on the subject, you will probably like to feel the changes and the new advents which have taken this sepsis to a farther paradigm than what it was in the pre-COVID days. To start with, I must say that unlike chronic diseases, in which there is a rapid shift or a paradigm shift in understanding at times, leading to a total disarray of the treatment modalities, the same doesn't hold true for sepsis. And why it doesn't hold? It doesn't hold because sepsis is not a disease. Sepsis is a syndrome, a final common pathway in which several diseases can conglomerate and lead to leading to the various consequences of organ dysfunction. So this itself speaks of it, that the very basic tenet of sepsis, that it's a dysregulated response, a dysregulated host response to infection leading to a life-threatening condition, itself makes it paradigm shift really impossible. Then when we talk about something new, what do we talk about? We talk about those fundamental points on which new avenues have been explored and new adjuncts have been pulled and some old adjuncts have been pushed. That is, the rope of the stadium has been bridged at times, it has been stretched at certain areas of its circumference and has shrunk in certain areas. So with this background, if I say that all the therapy of sepsis that we talk about falls into either of the three categories: causal therapy, supportive therapy, or adjunct therapy. Now, in this talk, I'm not going to talk about the definition, pathogenesis, and epidemiology because that will make it too long, and the subject of treatment itself is good enough to cover the new things for a period of 1 hour. So in order to keep myself restricted to the therapy for sepsis, I wish to tell you that in causal therapy, we talk about two aspects: source control and the timely administration of antibiotics. So we will go through each of this and try to find out what is new in context to what we knew in our pre-COVID days. The good thing is that in causal therapy is the actual therapy. If this causal therapy is not instituted correctly or in the proper manner or in the proper fashion, no matter how good is the supportive therapy or the adjunct therapy, things will not work to our interest. So this is the importance of causal therapy, that it is the first and foremost therapy which is directed to the cause of sepsis. Supportive therapy encompasses a series of measures which by itself may not lead to the desired goal, but which can largely influence the causal therapy in reaching its goal if they are instituted properly and on time. Fluid resuscitation, ventilation, steroid usage, vasopressors, renal replacement, all are supportive therapy. By themselves, they will not lead to a change in an outcome of sepsis, but with causal therapy, they can manifold increase the rates of positive outcomes. The third form of therapy is the adjunct therapy. So the adjunct therapy is that they don't have any specific role always, but given the conditions for them to flourish, given the conditions of the host, so they may do miracles, they may fail also, but at least they are not going to cause any harm. So when we talk about adjunct therapy, we include only those therapies which are unlikely to cause any harm, not likely to cause any major benefit, but if the conditions are congenial and if the susceptible host has the spectrum to provide the flourishing of this therapy, then it can achieve good result. So they are probably decided upon or instituted towards the end, when a good outcome based upon causal and supportive therapy alone seems to be difficult to achieve. So first, let us talk about the causal therapies, and out of causal therapies, the one that is most important in sepsis is the source control. So source control includes all those actions in the process of care of sepsis that controls the foci of infection and to restore the optimal function of the site of infection. We know that whenever the foci of infection is the lungs or the liver or the pancreas, or for matter any other viscera or the other organs like the skin or soft tissue, the optimal function of that organ or that site gets affected. So measures are taken to control the foci of infection and restore that function. For example, let us assume in appendicitis or cholecystitis, the source control measure is excision or removal. For a perforated ulcer, it is repair. For an anastomotic leak, it is a diversion with or without excision of the remnant sac. For abscesses and infected fluid collections, it is drainage. For necrotic tissues, it is debridement. So likewise and like code, source control is a cornerstone in the treatment of infectious diseases, and especially if the patients are in a shock or in severe sepsis, it is of utter importance, is an urgent matter. So no time should be lost in source control. So in this source control, our understanding has been more or less same to what has been during the pre-COVID times. So what is the important thing is that to realize that what are the problems of source control in critically ill patients. Now in critically ill patients, we all know that it is the time which matters. And it is the reserve of the patient which determines that if the intensity of source control would likely to cause a damage or a collateral damage in the patient. So less room is available for compensating for the consequences or complications of procedure. One, we don't have that scope to allow complications to occur. And even if they occur, it may be too more damaging to the patient. And even if they don't occur, the normal side effects can be more damaging to a critically ill patient than a normal patient. Second is the urgency of the need of source control is different. Many a times we realize that at point we think that yes, it has to be something, source control has to be done urgently. But in between individuals, there is sometimes variation. Some people believe that it can be delayed by a few hours. Sometimes some other professionals, some surgeons may feel that it may be delayed by a day. So there is some kind of variation even within the professionals concerning the urgency of the need for source control. So that is problem number 2. But all said and done, it has been seen by Bloom's that 42% of patients with septic shock require some form of source control, a little less than half of these patients, and a majority of them, more than 4 out of 5 persons in which source control becomes necessary, it is essentially surgical. So that highlights how important is source control, without which a lot of other vehemently aggressive steps becomes meaningless. So the main evolution regarding source control has been in the post-COVID, in comparison to the pre-COVID times, has been an increase in the percutaneous drainage of abscess in many different locations. So earlier, those locations were restricted to certain areas. We know that pigtail in patients with an abdominal abscess or a soft tissue abscess in the pelvis, in the thigh, but these have increased manifold because of the increasing resolutions, the increasing power, the better transducers availability. It is possible to drain a lot of intrinsic sites which were otherwise not possible, either through CT guided or ultrasound guided. So this has been one focus on source control, which has changed a lot during these days. So if we talk about drainage, we talk about intra-abdominal abscess, chest empyema, septic arthritis, pyelonephritis, cholangitis, etc. When we talk about surgery, we include infected pancreatic necrosis. Of course, we give that interval of 2 to 4 weeks, depending upon surgeon to surgeon, so that the plane becomes available. Intestinal infarction, which is again one of the important causes in the elderly, those with pre-existing heart disease, if there is a vascular compromise leading to ascites, sepsis, surgery becomes so important. Mediastinitis, etc. When we talk about removal of access or devices, we mean infected vascular catheter, urinary catheter, infected IUCDs. When we cause of definitive control, we go for sigmoid resection for diverticulitis, gangrenous cholecystitis, we go for cholecystectomy, so on and so forth. So the recommended source control techniques have increased, their scope have increased, and their ease have also increased because of increased usage of percutaneous methods. But one thing you have to see that most of the times the recommendations are graded as DRT. Why it is so? It is because it is very difficult to do a randomized controls trial. You can't assign one group of patients to undergo drainage and another group of patients who have a collection not to undergo drainage, because that is not ethically correct. So there is no equipoise. So therefore, randomized control trial is not the randomized control trial is the highest level of evidence, meta-analysis and RCTs. So it is not possible to do such studies. It is only possible to gain knowledge from the base of retrospective or observational studies. And therefore, these recommendations have a grade of D or E because the level of evidence is low. So if we see the different types of source control principles, when we do an open surgery, there is an exquisitely good chance for drainage, for debridement, as well as for restoration of anatomy and function. So open surgery undoubtedly is the best. But the problem is whether patient has the sufficient reserve, whether it gives enough room for the surgeon or for the interventionist to gain access and do all the good things without causing any collateral damage. Second is percutaneous drainage. If we believe it is good in drainage, to some extent in debridement, but not for restoration of anatomy and function. With device removal of like an infected catheter, infected IOCD device, etc., drainage becomes easier, but debridement and restoration of continuity is not possible. For disobstruction is meaning the word is not obstruction, so it may sound new to you, is like opening up some obstruction by use of techniques. It's like endoscopically driven techniques. So if there is a calculus which is giving rise to pancreatitis, by doing an ERCP, one can take out that calculi which is obstructing some part of the CVD. So that becomes a disobstruction. So that can cause a good amount of drainage. And it can restore the anatomy and function because the bile will pass through its normal path. But for debridement, it is not possible. If there has been an cholecystitis, cholelithiasis induced pancreatitis, and there is a collection, that won't get reduced by ERCP induced removal of the calculi because that room is not available for it. And of course, open abdomen management. So that includes drainage. So this is less performed nowadays, where something is opened and it is left to lie open so that the internal abdominal pressure is not increases. The same used to be done for cardiac surgeries earlier long time before. Now again with a better drainage. So drainage has percutaneous drainage has overtaken open abdominal management to a great extent in most of the spheres. So these are the various principles of source control which has been strengthened recently because of increased awareness, increased observation of better results. The second important thing in causal management, in causal therapy, is the timely antibiotics. And in timely antibiotics, we win two aspects. One, the timely administration of empirical antibiotics, followed by institution of definitive antibiotics once the organisms and their sensitivity, culture sensitivity becomes known. And of course, nowadays, followed by a timely de-escalation of the antibiotics when the evidence of infection has reduced or has vanished. So in this context, it is important to remember that when we institute empiric therapy, the indications for instituting gram-negative coverage has been modified a bit. Now we have nosocomial infections, neutropenic or immunosuppressed, immunocompromised due to chronic organ failures or chronic diseases of the liver, kidney, lungs, and heart, all should receive gram-negative coverage. Earlier, it used to be the nosocomial part gets divided, but now it is known that nosocomial essentially means both gram-positive and gram-negative because there is a lot of increase in the incidence of gram-positive nosocomial infections, particularly pneumonia. So similarly, with the gram-positive coverage is indicated for high-level MRSA, neutropenic patients, for intravascular catheter infection, nosocomial pneumonia, and so on. Fungal coverage is required, neutropenic fever in prolonged and broad-spectrum antibiotic therapy, positive relevant fungal cultures, and so on. So all these indications, even if they have not increased in numbers, they have gone some amount of permutation and combinations, and they have entered in the different zones so that the demarcation of the zones has undergone changes. Now, this is a broad division of the empiric antibiotics. Of course, the finer aspects depends upon the sensitivity as per the local antibiograms and the policy and the antibiotic policy of that particular place. But it is important to realize that we always, the previous guidelines have stressed that on blood cultures and other should be instituted. But it is very important to realize that blood cultures and biological samples should be obtained. But this should not delay antimicrobial therapy. So all efforts should be made so that the blood cultures and it becomes at the earliest. Sorry. So in 2019, the US has given a list of organisms which has the CDC has given, which it considers to be most threatening resistant organisms. Although we say that our profile of organisms or our antibiogram in India is much different because we have much lesser MRSA and they have much lesser gram negative. But if you see the list of serious threats and the list of urgent threats, there are a lot of common features that you can distinguish, like all the ESBL producing Enterobacteriaceae are serious threats as well as for us. All the drug resistant Streptococcus and the multi-drug resistant Pseudomonas are serious threats as well as for us. All the urgent threats like carbapenem resistance, Acinetobacter, Candida auris. Candida auris has been a huge problem in our subcontinent, our part of the subcontinent. Of course, drug resistant Neisseria and etc. is not there. So there are a lot of organisms in this list which are all also our problem. So with the researchers trying to focus on whether AMC or whether OXA or metal-metal activities are important, a lot of understanding has already improved, and in the coming days we might be able to touch upon the organisms and their characteristics, which becomes important. But the important thing is that multi-drug organisms are the potential threats for empiric antibiotic treatment, and one needs to have a cautious approach in that. Now, this is the WHO's list. This is the WHO's list of essential medication list in 2017, which provide us a guidance about the antibiotics, because this is called the AWARE group, which is the access. So as you can see, the watch and reserve. So this is the watch and reserve group, in which we have antibiotics which are strongly indicated and which can be used in any susceptible infections widely, which are in access, that is the ones in green, followed by watch, which wherever we suspect the resistant organisms, we go for this list, and the third is the reserve, all the newer and antibiotics, including of course colistin, polymyxin, everything that comes under the category of reserve, because they have to be used with caution. They have to be used when it is absolutely clearly documented that certain organisms have grown or outgrown, which are only sensitive to such drugs. Otherwise, it will again give rise to the a difficult situation where we will harboring multi-drug resistant bugs. So moving on to the second most important aspect is the supportive therapy. And in supportive therapy, probably the most important reason to think about is the fluid resuscitation. So the use of fluids other than crystalloids for initial resuscitation and volume replacement is currently not recommended. We have gone through a lot of studies from the after 2010, which have seen that the crystalloids are the primary choice, and the colloid administration either has no benefit, or some of the colloids actually increases the risk of renal replacement therapy or increases the AKI. So increasing concern that a positive fluid balance will have a negative impact on the prognosis, in contrast to what was classically shown in the reverse study long back. So at what point vasopressor should be started and fluid therapy should be stopped is still unclear. A lot of studies are already being pursued in this direction, that at what time frame vasopressors can be started, and the both can go simultaneously instead of trying to give more fluids. And the guidelines recommend still that norepinephrine as the vasopressor choice. So there is consensus about high dose fluid replacement in the first hours of septic shock for rapid normalization of DO2, because unless the perfusion is adequately met, the DO2 will not be achieved and circulatory function. But there is a big question about the certainty about the continuation of the fluids beyond a particular period of time. And if you look into this article, which has been published in 2020, they say that the fluid resuscitation in sepsis, the grade 30 ml per kg hoax. So why do they call it hoax? Because we have all been doing 15 to 30 ml ml per kg of resuscitation for quite some time, starting from 2007 to 2008. This is because they believe that this 30 ml per kg of IV fluid was based on the results of that reverse study, in which they tried to find the mean amount of fluid that the patients received before randomization. Before they were pre-randomization fluid, which the patients received, the mean of which was 30 ml, and that became a hallmark. Now the question is that the reverse study already had a mortality rate of 40% in the control group. So if the mortality rate is which was abnormally high in the control group, the mean volume of pre-randomized the fluid measurement that was given, is that good enough? So that was the biggest question which remained unanswered, and that was a stumbling block. 3 interventional studies in the later years, we all know the process, promise and arise, they have seen that liberal fluid resuscitation does not always improve patient-centered outcomes. They didn't mean it either that it has to be a restrictive fluid therapy, but yes, liberal fluid administration leading to excessive outpouring of fluids inside the vessels or inside the body will not give rise to a desired outcome. And because of our recent understanding that large volume of fluid administration may potentiate damage to the glycocalyx when this bolus is given too rapidly, further substantiates this claim or further strengthens our view is that yes, too much is bad. So we recommend an individualized, conservative, and physiologically guided fluid therapy in most cases, because that is the what has been found to be most prudent approach. So whenever we give fluid boluses in septic shock, a lot of newer understanding has been accrued on the proposed mechanisms of cardiovascular dysfunction. And if you see the slide, this is a bit complicated slide, but don't have to look into everything. You see refractory shock, you see cardiac failure or multi-organ failure, or all the outcome of increased oxidative stress, increased inflammation, and baroreceptor mediated decreased sympathetic activity. And to all of them, by complicated network of or twines of arrows, they are related to either shear stress, a reduction in the arterial tone, or an increase in the atrial natriuretic peptide. So these are all the consequences of fluid bolus therapy. So large volume of resuscitation may lead to serious collapse by direct cardiotoxicity. So this mechanism has been raised and has been intensified because this has been shown in more than almost 8 or 10 different studies, of course, observational and clinical trial included. So if we want to improve our outcome following fluid boluses and judicious fluid administration, it is important that the resuscitation fluid should be able to preserve the endothelial glycocalyx. And resuscitation fluids differ in their ability to protect and restore the endothelial glycocalyx. While FFP has been identified as the one which is able to maintain this glycocalyx to the best possible way, there are no ways which we have not been able to detect about the other fluids. We know that we don't give FFP, we give the normal crystalloids, but among the crystalloids, how much of which is actually able to preserve this endothelial glycocalyx to what extent is still not so clear. But one thing is very clear is that the principles of fluid management and stewardship in septic shock should be followed, and the 4 Ds and the 4 phases of fluid therapy should be noticed, recognized, and acted upon on the basis of this model that Manu Waldron had given, the ROSE concept: resuscitation, optimization, stabilization, and evacuation. This is based upon an understanding on the ebb phase and the flow phase. It is the ebb phase where the patient gets fluid for resuscitation and optimization. Now, as the move from optimization to stabilization, during the flow phase, if we give too much of fluid, then there is a possibility of third hit and fourth hit. Third hit is global increased permeability syndrome, and the fourth hit is risk of hypoperfusion, from where it has to come down and reach the baseline. So this is an important concept, and the 4 questions of relevant is when to start, when to stop, how much to start and how much to stop, and when to de-resuscitate and when to stop de-resuscitation. Each and every step is important for the intensivist, because a lot of hemodynamic changes can occur if this is not followed. So the potential consequences of fluid overload on end organs has been found to spread across the CNS, the hepatic, the abdominal wall, the respiratory, the GI, and the visceral, cardiovascular, renal, I mean everywhere from head to toe. So therefore, it is very important to understand that fluid overload in itself has an important impact on the outcome in patients with sepsis. This has been recognized, acknowledged, and a total change of practice driving towards restricting fluid that is causing de-resuscitation and after the stabilization phase has been reached upon in the post-COVID era. So, like we used to have antibiotic stewardship, fungal stewardship, we are also practicing fluid stewardship, nutrition stewardship, steroid stewardship, oxygen stewardship. So all stewardships are in foray, and a series of coordinated interventions to select the optimal fluid, its dose and duration that results in the best clinical outcome, and prevention of adverse events and cost reduction is essential. And this is highly individualized. I think it is too difficult to expect a result in any single randomized control trial or a couple of randomized control trial and meta-analysis, but it is only our individual understanding of the facts and figures and a coordinated action and prevention, and also limitations of the cost. So it is now the time for fluid stewardship. The second important supportive therapy is ventilation, and the effects of non-invasive ventilation has been tried and tested in so many different ways during the COVID that essentially a lot of knowledge about this form of ventilations and its applicability in sepsis, both severe sepsis and septic shock patients, has been tried and tested, which equivocally good response. So if you see this study, which have found the non-invasive ventilation and awake proning in patients with coronavirus disease with respiratory failure, they wanted that initial aerosol generating procedures were avoided whenever were possible. We all know patients were intubated as early as possible. With experience, the physicians realized that mortality of invasively ventilated patients were high, and it was not easy to extubate many of these patients, and they had all other problems, including secondary infections. That led to an upsurge of NIV, HFNC, and awake pruning. And the popularity of this, it increased in patients with ARDS. And as it increased with ARDS patients, their popularity also increased in septic patients with ARDS. So if you see the respiratory drive in patients with sepsis and septic shock and how we modulate it, this is the change in esophageal pressure. This is monitored, that the transesophageal pressure. And if you see the monitor, then there is a linear relationship, which essentially that patients with sepsis and septic shock of extrapulmonary origin present elevated respiratory drive and effort. And this can be effectively reduced by HFNC. Now, this have been seen earlier also, but essentially this became noticed much later. And this is one of the studies, one of the large studies which had shown it, which was again published last year. And again, another study which was published in last year showed HFNC versus non-invasive ventilation to prevent re-intubation in sepsis. And that also among sepsis patients, there was no difference between HFNC and NIV in the rate of re-intubation at 72 hours. So therefore, it became more and more clear that there is not much of difference in the outcomes, whether we use NIV or HFNC. And if we want to avoid the discomfort associated with NIV, as well as also we know that with NIV, we are not able to prevent the lung protective ventilation, because definitely 6 ml per kg is out of question. So if the patient is having ARDS, that will be detrimental. So HFNC has become a very good option. So again, this was a comparative study of high flow nasal catheter device and non-invasive positive pressures or sequential treatment in sepsis patients after weaning. Sequential means after the patients were extubated, sequentially the patients were put on either HFNC or NIPV, and there also it was found that HFNC and NPP had similar efficacy in the sequential treatment of septic patients after weaning from MV. So compared with the NIV, those who were extubated had a lower rate of such complications like reflux, aspiration, and facial ulcers, and they were also more comfortable with less delirium in comparison to NPPV. Of course, that is because probably the medications used were much less in HFNC in compared to NPPV. So this again produced a tremendous impetus to the use of HFNC in patients with sepsis and in patients with sepsis who were having mild to moderate form of ARDS. So next important was that during mechanical ventilation, there were a lot of earlier indications that dexmedetomidine can be a useful adjunct which can reduce the opioid usage. So there were winds from all directions that let us cut down opioids, let us use dexmedetomidine. But this was one of the meta-analysis based upon the results of reported studies, which has been published in March, that is only the first week of March, which suggests that dexmedetomidine did not reduce all-cause mortality in mechanically ventilated patients with sepsis, but it was associated with decrease in the length of hospital stay, ICU length of stay, and the duration of mechanical ventilation, although it increased the risk of bradycardia. So probably from this, we know that total abolition of opioids or such drugs may not be possible, and total reliance on dexmedetomidine cannot be conferred upon just for the cause of mortality, although regarding the length of stay and etc., it may have a significant form of reliance. So it is very important to realize that it is the results with dexmedetomidine are not as encouraging as it was earlier, but still they have a place on selected group of patients in whom it may provide benefit. Now, this is one more important aspect which has come up, that is also gaining practice and wider recognition, is the ventilator dependence risk score for the prediction of prolonged mechanical ventilation in patients who survive sepsis or septic shock with respiratory failure. Now, this group of patients are unique patients because these patients produces uncertainty in terms of their mechanical ventilations. Once they're weaned off, shifted from the ICU to the ward, and then again sometimes they have to come back to the ICU. They are again put again on ventilator, and this cycle goes on and off. The readmission into the ICU becomes high and low. So the ventilator dependent risk factor was calculated based upon these 4 variables, which were adjusted by the proportion to their beta coefficient, because that correctly modifies the confidence interval. So these were given as previous stroke and platelet 2 each, and the pH and FiO2 requirement of more than 40% at 1 point each. And this was an important addition because this could predict to a certain extent clearly that what can be the ventilator dependence of the patient after prolonged mechanical ventilation. The other important aspect of supportive therapy has been the use of steroid. Now, steroid treatment of sepsis and septic shock has been a matter of debate since long. We all know that. So treating all or treating no patients with corticosteroids, we know that there lies a vast middle group of patients in whom prescribing hydrocortisone to some extent of septic shock is practiced. So the documentation has to be proper. So this middle road approach recognizes that the average treatment effects reported in many trials may not be a good estimate of the likely benefit for each and every patient. The actual benefit experienced by individual patients in trials and in ICUs can vary dramatically because the trials don't pick up those middle road approached average patients. They only pick up the ends of the line. So there is a need to incorporate individual patients' likelihood of benefit into our bedside clinical decision making regarding the use of steroids. So we all know that when it was first used, it was used in very high dose in clinical septic shock. Supraphysiological doses of steroids resulted in hemodynamic improvement. Then everything went for a toss. And finally, in 2018, two trials came. One was the Approaches trial, where hydrocortisone plus fludrocortisone in patients with septic shock. And then came the adrenal trial. Of course, there was no significant defect, but a significant difference in mortality was identified with an absolute reduction of 6%, which is a good big number. So, whereas in this adrenal trial, there was no difference in the 90-day mortality. So, these were very important, that why there are so much of disparity in the trials, when more or less their structure, their formatting has been similar. So treating all or treating no patients with corticosteroids, again, lies a vast middle ground, and it is that individual or the actual benefit of that middle group that was missed in the trials. So that was so if you look into this study, if you look into this study, you will find in the placebo, the death rate was almost similar. That is only 28% was dying in the placebo. Whereas in the placebo, here in the Approaches trial, it was 49%. So that when this difference in the placebo is so much, 28% in one and 49% study, so the difference, it is unlikely to be shown in the later in comparison to the former. So then again, in the supportive therapy, we all know that the Marix protocol, and therefore there has been multiple studies which have not been able to relook into those studies, and they did not obtain the results which Marix had observed. So there has been a systematic review and network meta-analysis of studies based upon the use of steroid, ascorbic acid, and thiamine in adults with sepsis. And what they found was that the component of glucocorticoid and not ascorbic acid or thiamine is shortens actually the time to resolution of shock. So this was some network meta-analysis findings. So this has certain importance, and so the importance of glucocorticoids has been strengthened at the cost of thiamine and ascorbic acid. Whether the usage of ascorbic acid and thiamine has reduced, I can't say, but at least theoretically, there has been more pillars to the roots of glucocorticoids. So if you see that most of the time, if you see that whenever there was an additive effect of this drug, it has been found that glucocorticoids shorten the duration of mechanical ventilation, and the combination of glucocorticoid and fludrocortisone improve the short term as well as the long term mortality. So that fludrocortisone has no meaning, has again susceptible to challenge, because glucocorticoids shorten the time of resolution of the shock and duration of the mechanical ventilation, and fludrocortisone actually helped by combining in terms of short-term mortality, so which otherwise would have remained unchanged. So this has been a significant importance. So this gave rise to the concept of stress dose of steroids in septic shock. So if to check whether it is vasopressor dependent septic shock, if there are strong indications for steroids like chronic adrenal insufficiency, chronic systemic steroid administration, hypotension, refractory to fluid and vasopressor, and yes, then strongly consider steroid. If there are relative contraindications to steroids like paralytic infusion, diabetic ketoacidosis, HBV, HIV, recent surgery, active, then probably avoid steroids. And for others, expert judgment based upon the multiple factors like how sick is the patient, how are they responding to treatment, how much is the physiological reserve, what was the prior exposure to adrenal suppressive medications like phenytoin, rifampicin, etc. So all of these are important to delineating and determining their response. So a careful consideration of each patient based upon their clinical condition is necessary for starting the stress dose of steroids, by which we mean a dose of 200 milligrams per day. Next, coming to the important form of supportive therapy, which is the vasopressors and inotropes. Regarding vasopressor management, if we follow a simple diagram, and the understanding that has evolved is that we use norepinephrine as the first line vasopressor. If central axis is not yet available, considering initiating vasopressors peripherally. If cardiac dysfunction with persistent hypoperfusion despite adequate volume status and blood pressure, consider adding dobutamine or switching to epinephrine. If MAP is inadequate despite low to moderate dose of norepinephrine, consider adding vasopressin. And we all know that we all are going to start with the threshold for starting vasopressin is coming lower and lower. So effects of a very early start of norepinephrine in patients with septic shock has been shown that starting norepinephrine immediately to stabilize hemodynamics, defend the organ perfusion. Initiation of low dose vasopressin shortly after norepinephrine helps, and streamlining approach to vasopressors with epinephrine as a second line vasopressor is useful. And whenever the stress dose of steroids are administered earlier to the sickest patients, this is helpful. So based on this cumulative approach, if one sees, then typical time course therapies in septic shock has been first lot of fluids, gradually with norepinephrine, followed by vasopressin, then dobutamine to reduce the afterload, then others, and finally stress dose steroids. Now that usual approach is gradually, this approach is gradually changed. And what we find now is an approach where more and more things are getting to start early, that close to the fluid, you also start the norepinephrine. Then this time between norepinephrine to vasopressin is less, vasopressin to epinephrine is less, and stress dose is early. So this is also an important understanding which has evolved over time, because this is the accelerated goal-directed therapy, which is designed to escalate rapidly and achieve resuscitation goals within the initial golden hours of therapy, because further delay, we know, is only going to increase the scope and limit of oxidative damage. Next important supportive therapy is the renal replacement therapy. So the pathophysiology of septic AKI is still partially understood. It is not fully understood. There is a clear observation that there is minimal structural kidney lesions, even in clinically severe AKI. In the early phase, it is mainly functional changes, including microvascular shunting and tubular cell stress. And early intervention could largely improve this kidney function and prevent persistence. But currently, no pharmacological treatment is available to induce renal repair in patients with established septic AKI. So the current standard of care is treatment of infection, adequate resuscitation, and avoidance of further nephrotoxic insult. So if renal function becomes insufficient to maintain physiological, it becomes necessary to start, it becomes important to start the RRT. So if you see the trajectories after kidney injury, you see that there it follows a very complex trajectory here, the blue lines where there is a late sustained reversal in comparison to the red line where there is a never reverse, but both of which has more or less subclinical AKI and normal kidney condition to start with at that. So in which direction, the way this direction moves, this trajectory, and the way it is largely determined by how much kidney perfusion gets affected after the first hit. So first hit essentially occurs before 3 days. So about 1/3 of critically ill patients with AKI develop persistently decreased kidney function, and this AKI progresses to CKD or chronic kidney disease. Now, this has been one of the major challenges, and in the days to come, it will be going to be again an impending challenge for us. So the landmark trials regarding the timing of renal replacement therapy in critically ill patients have not yielded an unequivocal response, but we mostly rely on the ATTI-2 trial and the START AKI trial. So we don't say that start very early. We only say that start to don't be late, but when it will be late, it is very difficult because there is no significant association between CRRT use and the 28-day survival in SAKI. Of course, there is a gradual shift towards SLED from CRRT, but still there has been no difference in the outcome. So the cytokine response after therapy. Now, when we finish off with the supportive therapy, the third form of therapy that remains is the adjunctive therapy, which I told they do not confer any proven benefit, but yet cause some benefit without causing harm in selected group of patients in selective situations. Now, if we see the cytokine response after treatment, we see that the cytokine storm, which has been a recognized entity for long, but which has been given importance after this COVID, can take a peculiar turn from here, because, and this is the phase where the immune suppression is actually started, its beginning is a concavity inwards. So, and here it is the immune paralysis. So a lot of times, both normal and abnormal immune response following an infectious insult causes the recovery and the hemostatic balance to proceed in opposite direction. So it is here that it's some effect of cytokine, of absorption techniques like cytosorb. But again, this is the phase where it is probably causing some benefit. And the moment the patient shifts to somewhere here, it is unlikely to cause benefit. So this is a very peculiar situation, because extracorporeal blood purification occurs by different techniques, convection therapies, absorption therapies, a combination, or etc. And it is still not clear that based upon the pro-inflammatory and the anti-inflammatory response, at which particular stage, which form of therapy would be the best. But what is known is that both inflammatory mediators and big bacterial toxins can be removed by this therapy if that small window which exists, that can be assigned upon. If that can be explored there, but it is very difficult to get a good amount of evidence, because it is a randomized controlled trial showing such a benefit is nearly next to impossible. So this was presented in recent times in ISCCM, the COMPACT-2 trial, coupled plasma filtration adsorption, and it was seen that this would be harmful in treating with patients. So this came to be rescued, that all the extracorporeal techniques that are coming needs to be subjected to a clear criticism, so that they should not be misused, giving rise to a lot of collateral damage. So this is on the polymyxin or the todimyxin or the polymyxin B hemoperfusion for sepsis. And here also you can see that this was a 2020 study. There was a significant association between its efficacy and the baseline SOFA score. So higher efficacy was observed in patients with medium SOFA scores, so in the range of 7 to 12. So promising a hypothesis for the same is good, but using it in a patients with very high SOFA score may not be useful. So that again brings in some doubt about this form of therapy. So there are different ways we can see that molecular mechanisms have been targeted, and therapeutic blood plasma exchange has been considered as one of the options in sepsis as a form of adjunctive therapy. But again, we have seen that this form of therapy is unlikely to yield benefit in those patients who have received some other form of adjunctive therapies before. Sorry. So this therapeutic plasma exchange may be more effective than hemodialysis in patients treated with sepsis-associated DIC. So since sepsis-associated DIC patients had a very, very poor outcome in most parts of the world, therefore this importance of therapeutic plasma exchange was explored widely in both US and Europe, and it has been found to be of selective benefit. Now, coming to the other important adjunctive therapies which have been gaining importance is the immunotherapy. In immunotherapy, there are both immunosuppressive as well as immunostimulatory compounds. And in both of these categories, maximum study has occurred with anti-TNF alpha and GM-CSF. Others have been very limited by their designs and trials. And it has been seen that during the first signal, that is priming, there are a lot of activators which are activated from the surface of the monocytes that causes the move towards the second signal, that is the activation. And these bacterial components, which are called PAMPs, that is the pathogen associated molecular patterns or damage associated molecular patterns, they have different roles. They have different actions on the cytokines. And if they can be selectively cleared off, because this immunotherapy can selectively cause a clearance of the PAMPs, so that can give some good result. Although it is too early, but it is important to realize that degenerative microcirculatory disorder during sepsis is being recognized and believed to be the most important culprit which is producing the capillary leakage. And that capillary leakage is giving rise to vasodilatation and ANG2 release. So this excessive immune response which is producing to leading to capillary leakage can be reduced if this form of therapy is used. The fourth important is the use of intravenous immunoglobulins in sepsis. This has also been studied in the past few years, 2-3 years, and it is believed that both innate immune system and adaptive immune system are responsive to a mixture of immunoglobulins, and therefore enriched immunoglobulins like IgM enriched, IgA enriched immunoglobulins can have a role in these patients. So IVIG is a treatment option with high costs, but with some variability, and if it is mixed, then it can produce some good response. So there has been study, although this is a single center retrospective study, it has found that IVIG administration in patients with serum sepsis and low serum IgG levels were associated with poor prognosis. And last but not the least, there is a lot of knowledge flowing about AI in sepsis, and the electronic medical records are being structured to find out the vital investigations, treatment, and other notes, that is from the unstructured data and the structured data. So there has been text mining, and the diagnostic algorithms are being created. And from these diagnostic algorithms, prediction algorithms are being created 4 hours, 6 hours, 12 hours, etc., in a time-dependent manner, so that we are able to detect early that when sepsis is not possible to, or it is irreversible. So using existing data sets of genetic expressions of septic patients, the AI systems are working, and the approach using genome-wide association studies together with AI using machine learning methods are able to identify some markers. So once we are able to know those markers, it will be easier for us to tentatively explain the reasons why steroids are not working, the reasons why antibiotics are not working, the reasons why RRT is not resulting into renal recovery, etc. So such genomic markers is very important, will become important from prognostic point of view. At the end, I should end by saying that evidence-based therapy still consists of basic causal and supportive measures. Adjunctive interventions such as blood purifications or targeted immunotherapy largely remain without proof of effectiveness so far, but certain aspects are very convincing and very on an optimistic path. Despite all efforts of experimental and clinical research, the ability to positively influence course and outcome is still limited, and investigation of strategies aiming at rebalancing the profound immune dysregulation, which we all know of today, but which we cannot quantify till date, during sepsis and septic shock, seems to be a promising goal, and for which I said that molecular targets during genomic markers and AI can pave the way. So thank you once again, and my profound thanks and gratitude to the ISCCM Visakhapatnam team for their kindness and giving me this opportunity. Thank you very much.
Thank you, sir. Thank you so much for your excellent presentation on the present guidelines, and what is the new has been clearly explained in treating the patient with sepsis and septic shock. I request audience who are having questions.
I think there are some questions in the chat box.
Me. How are you?
There aren't any.
Sir, can I have one question?
Yeah, please.
Yes, sir. Presently, in scenario of CRE, carbapenem resistant enterobacteriaceae, shall we? The number is increasing.
Absolutely. It is
Yeah.
the number is increasing.
Increasing, and
And-
shall we start a new BLI like ceftazidime avibactam as a empirical therapy in this scenario?
See, ceftazidime avibactam as an empirical therapy is not a good idea. Why I say that? Because whenever you see that OXA 48 or OXA 23, we are still getting something, or our problem it is still metallo-beta-lactamases. So NDM1 and 2. So probably we should be able to get a good respite once we get that drug cefderichol that is on the pipeline. It has not yet reached. But till that time, ceftazidime avibactam can be selectively used. That is no doubt about it. But since we are having mainly metallo-beta-lactamases and not OXA, so we should be careful in limiting the use of zavicefta for that matter.
Okay, thank you. Achyut?
Yeah.
Anirban. Hi, Achyut sir, Rajesh.
Yeah. Go on.
One question. So the extension to Dr. David's question, okay, ceftazidime avibactam as a plain solo therapy because we face more of metallo-beta-lactamase is fine. What do you think the idea of ceftazidime avibactam plus estrione as a combination therapy?
Ceftazidime avibactam plus
Estrione as a part of escalation
estrione.
therapy, cholesterol.
Yeah, but that is going to tremendously increase the rate, the cost of therapy. So if it is supplied in a government hospital where it is available free of cost, it is fine. But other options can be explored. What are the other options? There are a lot of EDTA preparations. We have meropenem EDTA. We have the Ceftra, this LRS is there. So all those can be explored before we can think of such expensive combinations. Because if the report is sensitive, it will take care of the varieties. So we still don't know that whether it is OXA or MBL. So, but let us assume that it is MBL. So then this EDTA containing compounds can work.
So my whole idea was especially for CRE, the Enterobacteriaceae group, where because the usual escalation policy, what I think most of the people agree with me, is escalation from a carbapenem to directly a polymyxin based therapy rather than something in between. So the idea of giving polymyxin because we have some options for the Enterobacteriaceae, polymyxin will have a broad other gram-negative coverage too. So if we know the organism is belonging to Enterobacteriaceae, why don't we have an intermediate?
We know. Actually, our main idea of bringing BLI into focus is that so that we can save both polymyxin and colistin for the latest. Otherwise, if you see the way tigecycline resistance have increased, the same thing was going with colistin. We were not able to save these polymyxins for the extremely sensitive, like the aware group, the reserve group. So BLI came as a respite, and in India it is ceftazidime avibactam, but in other places that varvobactam also that has also been combined with other beta-lactamases. So therefore, I think that this acts as a respite and acts as a bridge so that we don't jump our guns straight to polymyxins.
Okay. Okay, thanks for that answer. And I'll have one more, I just want your insight regarding this. So, what?
Can you speak a bit louder? Your voice is.
Can you hear me now?
Yeah, I can hear you.
Okay. So my question to you is what's your take on are we getting a better marker for the diagnosis of sepsis, something better than procalcitonin, or what's your opinion on the newer markers?
Procalcitonin was never a diagnostic marker for sepsis. Procalcitonin was only for de-escalation of antibiotics.
Yeah, agreed.
Because procalcitonin was misinterpreted as if procalcitonin is high step-up antibiotics, but this was never found in studies. All the studies said that for de-escalation. So getting a single marker for indicate sepsis is next to impossible. because sepsis doesn't follow a single lineage of inflammatory pattern. It follows a several circuitous and tortuous inflammatory patterns that involves both pro as well as anti-inflammatory cascades. So if you stretch along TNF alpha, IL-6, IL-8, you will all find dips and dips. That sometimes something is rising, sometimes something is coming down. So in such a scenario, you cannot choose or find a marker which is consistently increasing or consistently coming down or consistently stable. So it is very difficult to pinpoint a single. All of them failed, including Presepsin and all.
So agreed completely. Like, do you think, are we near close to something like, troponin for MI? Like, are we something close to an?
We cannot have a single troponin kind of a situation with sepsis. At the most, we can have a battery of markers and that again, it will depend upon AI based upon the collection data, so that we can make some kind of like a convoluted system of markers. If this is high, this is low. If this is 3 times, this is 5 times, this is 1/5. So some kind of information that may still a possibility, but a single individual marker consistently increasing or decrease is an unthinkable situation right now.
Okay, thank you.
Dr. Anirban, regarding the fluid resuscitation and deresuscitation, is there any timeline to start deresuscitation or the clinical parameters that we follow?
Exactly. It is a very good question. If you see that beautifully has been published by Manu Malbrin's team, in that they have tried to clearly chalk out the exact strategy that from optimization to stabilization, this plateau phase lasts over several days, which people used to think lasts for hours. It lasts for several days. So whenever it is lasting, and you know from the graph that the plateau phase has reached, so it is that point of time that deresuscitation should start. As early as we are able to start deresuscitation in the plateau phase, the better is the outcome and the lesser is the chance of cardiac dysfunction due to fluid accumulation.
Right. And what is the role of albumin in the resuscitation? Do you think it has
albumin? It is still believed that albumin is the single most colloid that can be used in septic patients if required, and that becomes a necessity when the amount of crystalloid needs to be limited because of the increased risk of organ damage in patients with pre-existing kidney disease, cardiac disease, so on and so forth, in whom even little amount of extra crystalloids may cause some harm. So albumin is probably the only and the best suited colloid that can be given for the patients during resuscitation. Of course, it has no role in maintenance.
Right. Do you specify any particular indications, like very clear-cut indications for albumin in resuscitation? You said it's chronic liver disease or too much of crystalloid required. Is that the indication, or can we?
Where do you require too much of crystalloids? One, if the patient is having a cardiac disease with a poor LVF, with a poor ejection fraction, if a patient is either a CKD or a patient with diabetic nephropathy with some amount of kidney disease. So now in all these patients, wherever fluid is likely to require, you don't wait even for the patients to remain stable with fluids for a few days. The moment it achieves optimization ends, there only you can start with albumin, so that no further crystalloid is given during the plateau phase also.
Thank you. Any more questions? Dr. Monmara, sir? Do you? Dr. David, sir?
Yeah. So,
yeah. Please go on.
Chit, please. Thank you, Anirban sir. Very nice session. Very good talk on sepsis and present guidelines, present management. What is new is clearly explained. I think we are all get benefited and it can make use of this in our day-to-day practice. Thank you, Achit. Thank you all the audience. Please, Achit, close the session.
Yeah. Dr. Mohan, sir, do you have anything to add? Dr.
Sir,
Mohan.
what is there?
Yeah,
When
please.
all people are there, what is there to add, sir?
Right. Okay, sir. Thank you. So from the team of ISCCM Visakhapatnam, we thank Dr. Anirban Home Chowdhury for his excellent lecture on the newer concepts in sepsis, and he has thrown light on many newer aspects which would probably influence the outcomes. And we thank for your time, sir, and especially when you're busy with your critical care 2022 preparation, you spared some time for us, and we thank very much for that. And we will send you a certificate of appreciation in the next couple of days in PDF format, so that you can take a printout. And we thank very much. Thank you very much for this effort, sir. And I thank all the audience for logging on to this session and participating actively. And we will try to continue these academic activities as many as possible in the months to come, and over the next few months to come. Thank you.
Thank you very much, Dr. Achyut. Thank you once again, and good night to everyone.
Yep. Thank you, sir.
Thank you, sir. Okay, Achyut. Bye.
Yes, sir.
Thank you.
We can make it physical from next time.
Sure.
We'll make physical, sir. Next session will be physical only. Okay, sir.